Welcome to the MS Academy. This is our 5th of November. It's a special day across the world, actually, and not only in the UK, but also in the US, obviously. So the topic today for the webinars are clinicians equipped to promote brain health and empower self-management and self-efficacy in people with multiple sclerosis. I'm joined today by Professor Matthew Cripps, who's the Director of Behavioural Change, NHS England and NHS Improvement, Christine Longhinotti, who's a clinical psychologist in Central London Community Healthcare NHS Trust, and Rachel Horn, who's a journalist with multiple sclerosis and an honorary research fellow at Queen Mary University of London. Just to like to thank our sponsor. This webinar has received sponsorship from Novartis. The first session, however, has been delivered by the MS Academy. Although it is sponsored by Novartis Pharmaceuticals, the sponsor has had no input into the educational content, speaker selection, or organization of the session. So these are the objectives. The terms self-management and self-efficacy are related but refer to different concepts. They're very crucial to support people with MS, to help them control their behavior, motivation, and social environment, and organize themselves and think ahead. Understanding the importance of psychological well-being, resilience, hope, and good mental health, and how self-efficacy is directly related to these health behaviors. We'd like to review the key aspects, barriers, and benefits of self-management, and then when and how should brain health be discussed in clinic. And we hope that you as an audience will engage. There is an ability to ask questions, and we will try and address the questions in the Q&A session. So this is the agenda. We'll have 5 minutes presentation from all the panelists, and then we'll go into a round table, and hopefully we'll get some questions while we're talking so we can address those. So what is self-management? Next slide. So self-management really is a behavioral change. What we're trying to promote, in our MS practice with people who've got chronic disease, the behavior where they can actually self-manage and potentially self-diagnose some of their problems. And it's not a black and white issue. It's a grey issue, and people start off with some awareness, and then they have to move through desire, knowledge, ability, reinforcement phases where they have to sustain change in their behavior to help them do this. And we'll discuss some of the issues around this behavioral change that's required to shift people from being passive recipients of healthcare to being active participants. I kind of use this infographic just to illustrate the holistic management of MS, what we're trying to promote. As you know, there are MS-specific targets, and most neurologists or healthcare professionals working in the MS space tend to focus mainly on the MS-specific targets. But there are clearly non-MS targets, which are all around brain and metabolic and social health, and a lot of those have to be dealt with by non-MS teams, general practice, and other specialist teams. And the driver of that often has to be the person with the disease. And so this will be a discussion around how we get people with multiple sclerosis to engage in optimizing the brain, metabolic, and social health. And I'd like to use as an example urinary tract infections, because we do know that recurrent infections are linked to poor outcome, and they also lead to loss of quality of life and excess healthcare utilization. Next slide. So one of the things I've done over the last few years is developed a self-management portal called MS Selfie, where I try and promote self-management. And one of the things is to get people with multiple sclerosis to manage their bladder infections and to teach them how to, for example, interpret dipstick results and act on them. Next slide. And a lot of patients actually put in place with their general practitioners the ability to get a prescription as soon as they detect they've got an infection. At the same time, they drop a urine sample off for microscopy, culture, and sensitivity, and then they get a feedback loop from the GP if their antibiotic prescription, which was given in advance, needs to be changed in terms of antibiotic sensitivity. And in the future, I anticipate this may actually happen, asynchronously via the Patient Knows Best with NHS app, so you don't actually have to have face-to-face encounters. And I also use the platform to actually educate people about infections and how to reduce the risk of infections, not only bladder infections, it's general infections. And one of the advantages of activating people to monitor your recurrent urinary tract infections is that at least you can then actually count them and see how frequent they are. And if you actually fulfill the criteria for having recurrent urinary tract infections, which is 3 in 12 months or 2 in 6 months, you may need a referral to a urologist for further investigations. And so, it's not only about managing the infections, but also about creating the criteria for specialist referral. This is an old, by the way, this is an old problem. And just to say that the MS Academy, Ruth Stross and the MS Academy have published papers on a national system for home monitoring and home management of urinary tract infections. And they've also published some of the cost savings associated with this. So I would urge you to read Ruth's paper on this. This is just one example where, activating people with multiple sclerosis to take on the diagnosis and potential initial management of urinary tract infections can have a big impact. So and there are a lot of other symptoms that can do this. Anyway, I've said enough. I'm going to hand over to Matthew, who's going to now talk to you about barriers and benefits of behavior change. Matthew, over to you.
Thank you very much, Gavin, and thanks everyone for having me. I'm Matthew Cripps. I'm Director of Behaviour Change at NHS England. Basically, I run a team, the Behaviour Change team, and what we do is we're a team of specialists, of behavioural scientists, process engineers, knowledge managers and creative designers, and we add those skill sets into the work of other teams, whether they're improvement program teams or policy development teams, and use all of those skills and those techniques to help them enhance their impact by accounting for essentially human factors and the context in which change has to occur in order for people to make the choice to change their behaviour, and then how to help them turn that change in behaviour into a habit. So basically, behavioural science is basically about choice making. It's about trying to understand why people make the decisions that they do, how they make them, how they're receiving and accounting for the information that we give them, whether it's written, online, face-to-face. And as a result of understanding that, then understanding how we should therefore design and build the things we do for them in such a way that it helps them to choose to do what the evidence says that they ought to choose to do more often than currently occurs. And the principle is that basically if we do that, then we increase the rate of good choices and decisions, both our own in designing the things and supporting patients, and also those of others, whether that's our workforce or the population. Those of you familiar with behavioural science may well have heard of these two models. There's a number of models that are used by behavioural scientists and other behaviour change specialists. COMBI is probably the most common, and the one on the right is called MindSpace, which I'll come on to. Basically, COMBI is a model that helps you to understand what needs to be in place for a behaviour to occur. And also, when you, at the beginning of a behaviour change piece of work, understand what the current situation is that's acting as a barrier to the evidence-based behaviour occurring. And so I'll go through each one in turn. So the first one is capability. So if we aren't capable of making a change, then we can't do so. And capability may be that, as Gavin mentioned, if you're seeking support in a relatively specialist condition area from a generalist, it may be that their education back in the day didn't cover enough. It may be that they haven't been made aware of new practices, etc. So it could be that the clinician that someone with MS is working with isn't capable of delivering the support that would then enable the patient to make more informed choices and so on. But sometimes it's also the patient. So, for example, if we're trying to encourage self-management and we're recommending joining a yoga class, well, that's all well and good, but if you don't have any money, then you can't fork out the £10 a pop each week for your yoga class. Or if you need some technical skills in order to practice a certain area of self-care, if we don't provide you with those technical skills, if we don't teach you to use what they are and to use them, then you're not capable. You may have the opportunity to change your behavior and you may be motivated to, but if you're not capable, you still can't. Opportunity is a really good example of opportunity at population health level is access. So we can have put in place everything that would enable a patient to be capable, and we kind of, with them and via us and others, help them to be motivated to make a behavior change. But if they don't have the opportunity to, then it makes no difference. They still can't. Another example of opportunity that we often see, we work a lot in women's health, is often women are encouraged to go on long walks for their well-being, as just one example. But if that woman has a full-time job and 3 kids at primary school age, etc., then I'm sure the women in the audience, through their lived experience, know that you may as well not have bothered recommending a long walk, because there's absolutely no way I'm going to get the opportunity to do that. So understanding these things helps you to tailor what you then do with people. And then motivation is obviously, what are the benefits of choosing to do this behavior, and am I motivated to do so? And what we do is basically help work out what are where are we not filling in the gaps on those 3 areas, when in the way that we support patients, where are patients' barriers that we have a role in trying to alleviate, and so on, and creating basically the environment in which, if a decision to change a behavior is made, then that decision can actually be followed through successfully. The box table on the right, that's called mind space, and that's basically the 9 different ways in which the human mind receives messages and then chooses what to do with them. And it's used once you know what the things are that need to be put in place. So once you've done COM-B or something else to understand the barriers and drivers, once you know what the solutions are, how you frame them and who you get to convey the messages, can have a very significant impact on how many people choose to change their behavior. So messenger, a subset of messenger, is trusted messengers. So in COVID, a lot of people from ethnic minorities weren't listening to the middle-aged, middle-class males that kept saying, go and get your vaccination, basically because they're not a trusted messenger for very good historical reasons. So piece of work we did in COVID was to not change the message, but change who the message was coming from, and use community leaders and celebrities with different demographics and so on, and experts with different demographics as well, to increase the number of people who trusted one or other of the messages. One of the things we've done over time in the space of self-care is we've looked at why don't people choose to self-manage as much as population health evidence demonstrates would be ideal. And one of the reasons is the way in which that we try and encourage people to choose to do so, and shared decision making being an example of a really good way in which we can do that. So we worked with specialists in shared decision making and areas of care, and worked out, is there a way you can frame a conversation and provide that to a GP or a practice nurse or a pharmacist, so that when they talk to a patient, they do so as if they've already been very well trained in shared decision making and encouraging self-care. And is it simple enough that it could be done without major training packages and education? And the answers to all of that were yes. And I won't go through this in detail, but this basically is a conversation framework designed by behavioral scientists with clinical experts that, if it's followed, increases the number of people who choose with confidence and capability to include self-care within their informed choices on their pathway. And as you can see, the 9 components of mind space are covered through it, and I won't go through it in detail. I'm sure the slides will be shared, but basically that's how a demonstration of how you use these concepts to create a real thing that makes a difference. And the other thing is, a lot of this is generic. It doesn't necessarily matter what the condition is. So if you just flick through the next 3 slides to demonstrate, that first one was on psoriasis, this one's on back pain, the next one's on anxiety, and the next one I think is in menopause. But basically the reason I'm flashing through them is to demonstrate that very few of the words actually change, but the same process leads to the success at the end. So a lot of this stuff is generic, and learning it once means you can apply it over many conditions. I know this is an MS specific forum, but when you think about the number of patients who have to talk to generalists, you can see how this type of behavior change approach can be applied to have significant impact. Thank you very much.
Thank you, Matthew. Now, Christine, we're going to hand over to you.
Thanks very much, Kevin, and thank you for the opportunity to talk today. So I'm just going to briefly speak on the importance of psychological well-being and self-efficacy. So these are just my disclosures, just to say that I have previously received sponsorship from Novartis, MS Academy, and Merck, and Biogen as well. So, what I want to talk about today in these 5 minutes is just thinking about self-management from a psychological perspective and three kind of important areas that we need to keep in mind. So, one of them is self-efficacy, one is well-being, and one is coping styles. And we're just going to have a look in the next couple of slides of how these all kind of, integrate together between them. So I always find definitions really helpful. So when we're talking about well-being, we're thinking about it as how people feel and how they function on a personal and a social level and how they evaluate their lives as a whole. And there are 6 dimensions of well-being that we tend to talk about: personal growth, purpose in life, autonomy, self-acceptance, mastery over the environment, and a positive relationship with others. So self-efficacy is defined as an individual's perception of their ability to plan and execute tasks necessary to attain specific goals. So we can see here already how this relates into self-management, with self-efficacy being this kind of idea of how confident someone might feel or how able someone might feel to manage the symptoms of their MS. And we know that positive well-being is definitely a beneficial thing in chronic illness. So I wanted to talk a little bit about the overlap between coping styles and well-being. So a coping style is something that's used to manage the demands of a perceived stressor, and they usually have several elements to them: a cognitive element, so a kind of thought process, a behavioral element, so what someone does, and an emotional element, how someone feels. And coping styles are seen to be a modifiable aspect of well-being. So we know that if someone has adaptive or useful coping styles in place, they tend to have better well-being. So there's a few coping styles that the researchers looked at when working with people with MS, and this has shown that problem-focused coping, so an attempt to try and address the issue, something very practical, tends to be better, tends to have a more positive impact on well-being than some of the other coping strategies like avoidance, which is trying to distract away from the situation, not deal with the situation, or emotion-focused coping, which is a way to try and remove that emotional distress. So this doesn't really we're not really thinking about therapy here. We're thinking about that emotional distress in the moment, that kind of short-term coping. So we know that problem-focused coping is something that's really helpful. So when we think about how this relates to self-efficacy, self-efficacy is another modifiable protective factor. And we know that when people feel they have greater self-efficacy, their well-being is better. It promotes more positive relationships, greater autonomy, more positive affect, and higher optimism. And we know that adapting coping styles, again, lead to greater self-efficacy. So we can see here there's a kind of almost like a trifecta of things impacting on each other. Well-being is impacted by coping styles and self-efficacy. Self-efficacy is linked to well-being. It's all kind of related. And when they've done studies and when they've looked at this, the reason this is quite helpful for us as healthcare professionals is that self-efficacy is like higher self-efficacy has been linked to better treatment adherence, better disease management, better adjustment, and cognition as well, among different other factors. So us being able to promote self-efficacy can be something that's really helpful. So very quickly, I just want to touch on how we can do this in our clinics, how we might help to support self-efficacy. And there tends to be 4 ways that we think about this. So the first one is mastery experiences. So supporting someone to be able to perform a task successfully and be able to gain that mastery, that kind of ability or that feeling that they feel that they can do something. So being able to set goals to allow for those experiences can be helpful. Using mental imagery to imagine success, preparing for setbacks and monitoring performance are things that can be helpful. Trying to manage the emotional aspects of like with self-efficacy. So for example, reducing negative feelings and any kind of hesitation or avoidance. So it might be promoting adaptive coping skills. It might be about problem solving and trying to help people reduce their negative emotions, psychoeducation, and thinking about biofeedback, the impact on the body as well. Then there's verbal persuasion, which is someone being convinced that they can perform a task or action. So this might involve encouragement, and often this is from trusted or credible sources, important people. And it reminds me a little bit, Matthew, what you were talking about over COVID, that actually who is giving this information is really important. And we need to think about that as healthcare professionals to be able to signpost to the right advice and the right kind of people that are giving this advice that feel trusted and credible. And then finally, there's vicarious experience, which is observing other people successfully performing a task. So this might be trying to create opportunities to allow people to observe others. It might be like groups, if there's groups available, or YouTube videos or online support groups. And again, our role is really looking at those really good resources that we can signpost people to so they can see some of this. And the final thing I just want to touch on is this idea of CBT. So CBT stands for cognitive behavioral therapy. It's a type of therapy that we use often in clinical psychology. And the premise of it is that it helps people identify unhelpful thoughts and unhelpful behaviors that might be impacting on how they're feeling. So the idea is that our thoughts, our feelings, and our behaviors are all interlinked, and this can also have an impact on us physically as well. So if you think about when we're stressed, it does have an impact on our body as well. And there's a few different techniques within CBT that we can use. So psychoeducation, trying to provide good education for people, trying to help people modify their behaviors, trying to use SMART goals or problem-focused goals, and something called cognitive restructuring, which is where we look at those thoughts and we try and think, is there a way we can reframe them or think about them in a more helpful way? So that's just a quick whistle-stop tour of some ideas about supporting self-efficacy. Thank you.
Thank you, Christine. Now we move on to Rachel.
Great. Thank you very much. Thank you, everyone. My name is Rachel Horn, and I was diagnosed 15 years ago with multiple sclerosis. I was 43 years old. And I remember in one of my initial appointments chatting to my neurologist, who is now since retired, quickly, very, very much asking, what can I do now? You give me this diagnosis. And his immediate reaction was, go off and enjoy your life, which he might have thought was actually quite encouraging. But for me, it was actually the opposite thing I needed to hear. I'd just been diagnosed with this terribly unpredictable, chronic, potentially disabling disease. And I think I very much wanted to not just cope with my MS, but see how, if there's anything I could do to help myself, and also very much to feel like I was a partner. And also, I think it means that there's a gap, which means you might fall into relying on the internet for your, for some guidance. Okay, so the next few years with my MS, I was hit by a series of relapses. It was foot drop on my left side, also left side weakness, and I've got permanent double vision in my left eye, and obviously fatigue. So some of that was self-efficacy, making sure that I got orthotics, making sure that I got fitted with a brace, and making sure that the brace was helpful, and continuing to walk and exercises to help particular weakness. And again, with the eyes, it was contacting the DVLA, it was getting prism glasses, it was all those kind of small behaviors. But I think at the same time, I think a lot of the difficulties for me were mental. It was trying to come to terms with dealing with the disease, which it looked like was just a series of losses. And every time I thought I'd got things sorted and settled and picked up, self-management for dealing with one thing, it was shifting and evolving. And so I had to sort of, chuck away old therapies and ways of coping. The way I kind of solved that, or not solved that, but learned to live with it, was I got onto antidepressants, which I'm still on today, which helped take away some of that anxiety. And also for several years, I saw a therapist, which helped me, I think, come to terms with the diagnosis and the realization there are some things that I could no longer do, but let's adapt and think how we can go forward with this. I think there's one thing that comes in common with people who've had MS for a while is we assume everything that goes wrong is due to MS. Well, we can't help it. It's got so many symptoms out there. And again, if you go on the internet and you Google your symptom, it's going to pop up. So I think a few years back, I started getting a series of urinary tract infections. And I know it's something that Gavin, we've just seen a slide on. So I was convinced my MS was getting worse. And it was only after sort of a year being on antibiotics and thinking, you know, should I push to go on a higher disease, DMT, I realized it was actually a symptom of perimenopause. So I was then had to reach out to a gynecologist, get some blood tests, get on HRT, and the problem was solved. But I think what I kind of want to say is that because MS, you know, traditionally 3/4 of the patients who have MS are women, and it's a lifelong disease, so that there will be a series of fluctuations and quality of life changes for many of us women with MS. So again, that means that it's multidisciplinary, and that again we're involving, but it's also involving other actors. And a neurologist is a specialist in neurology, whereas a gynecologist, very different. So it's how do you pull those two together, and you know, with comorbidities, and that can be very challenging. Okay, I very much agree that self-management and self-efficacy, it is a worthwhile goal, but I think I'm just being maybe a bit more cautious here. Sometimes, I think again on an earlier slide, Gavin pointed out about social determinants of health. And sometimes I think we have to recognize, yes, we are treating MS, but we're also treating a person. And I am aware that I'm a white woman, middle class. I feel safe at home. I have money to engage a personal trainer. I can go see them to fix or to try and help. And also, I don't have any problems with transport issues or cultural or language issues. And also, I'm a journalist by training, so I kind of know where to find information. So I think it's all of those things that I think have been pointed out that we do have to be a little bit aware of. And especially with people from different backgrounds who might have different cultural approaches to, say, disease or to illness. That said, I'm really thankful that I'm on this call today, and I hope in the debate we can talk a little bit more about other things, which I think Matthew did brought up, and Christine, about having having a role in finding a new role or a new function, or just skewing things a bit, and as you say goodbye possibly to the person you thought you were, and then with a disease like MS, having to shift and say, okay, where is this going to take me, and where is this going to lead me? Thank you.
Well, thanks, Rachel. So, Rachel, you've really highlighted some of the issues that I think we should discuss. So, Matthew, coming to you first, being the NHS England representative. I mean, is there policy, first of all, to support this self-management, self-efficacy, and are there the resources available, and how do people access them?
I suppose the short answer to that is yes to the first, and a bit of a struggle for the second at the moment. But yeah, there are. So I think the new government's, their pledge to focus on prevention really supports this going forwards, because self-care, self-management is, as well as keeping yourself well and so on, it's a form of secondary prevention. You've already got the condition, but it's a way of minimizing its impact on you and avoiding exacerbation and so on. So I think that agenda will support quite heavily shifts in this area, and it's not something that NHS England hasn't been looking at. I've been involved in encouraging self-management, both encouraging clinicians to encourage it, but also enabling patients to do it if they choose to. Over the years, and there's been policy teams and so on that have done great work on both shared decision making and self-care, self-management, personalized care, and so on. And those teams, some of you may know that NHS England's been reduced in size by 40% over the last 2 years, but some of those teams do still exist, so it is still part of the future. So yeah.
So we talk about something going into the future. So Christine, I mean, Rachel brought up these things called social determinants. Instead of, we could potentially be widening the inequality we have in terms of access to healthcare. So what are the challenges, barriers, and how do we actually get to the people who just do not have the necessary ability, well, resources to do this?
Yeah, I think it's a really interesting and kind of very pertinent question. I think there's a few things that can act as barriers. I think one of the biggest challenges is kind of education and people knowing how to self-manage, because I think there has been traditionally like a culture in the UK not using self-management where, you know, kind of you go to a doctor and the doctor kind of fixes your problem, and then next problem you go to a different doctor, and so on and so forth. And I think in some ways it's our job as healthcare professionals to try and support that cultural shift. It's an ongoing conversation that we need to try and empower people to feel confident to be able to manage their health. A lot of people who come into my clinics are often saying, well, I don't want to do the right thing. I don't want to choose the wrong medication. I don't want to make the situation worse by not doing what I should be doing, as if there's always a strict right or wrong answer. And I'm not sure there always is with many of these things. But I think sometimes there can be a perception, particularly with MS, that feels often quite uncontrollable, of having someone in control can be quite helpful. And I think it's quite a powerful thing as well. I do think those social determinants come into it quite often, as I think Rachel wonderfully pointed out. You know, sometimes people just don't always have the headspace to be able to do this. If there's a lot of social complexity, then we're asking people to take on more and more and more workload, essentially. If you don't feel safe, you have financial problems, if you're trying to manage like an unsafe space at home, and then you're also being asked to manage lots of other things, I do think that kind of reduces how much psychological headspace you have to be able to do that.
Okay. Rachel, can I ask you, I mean, you've had well, I mean, you're pretty activated, and you've got a lot of self-efficacy. I mean, have you ever been given advice about management in relation to any of your symptoms?
Yeah, gosh. Sometimes, but look, I'll be honest with you, it is difficult because you do see a neurologist, what, 15 minutes, 20 minutes once a year. And I understand that there's a lot going on. You get in there, you know, you have your list of 4 or 5 things you want to go through. And the MS nurses, they're obviously quite overburdened. And I think there's a small part of me that kind of thinks, hang on, I'm kind of doing okay. So I do think I have to, most of it is by relying on something MS Selfie, which Gavin, which you put out. So reading that, going on to trusted resources, the MS Trust, Shift MS, and the MS Society. But it's, you know, I guess I think I know which sources are reliable. So I think that helps an awful lot. But, you know, so look, sometimes I'm come across people, you know, with MS, and they'll head down the rabbit holes, and they were very happily, I don't know, you know, laughing, bee sting venom, and they're convinced. And so I do think it does make a difference for reliable sources to step forward or see if there's any way they can sort of come across the headspace.
Yeah. So Matthew, I mean, let's just take a typical MS healthcare professional, be it an MS nurse or a consultant neurologist. I mean, how do they bring this into their clinical practice if they're not doing it at the moment? You know, how do they, for example, in their routine consultation, how do they actually trigger this change in behavior? Because it's not just about the people with the disease, it's about the healthcare professional or the contact with the healthcare professional. Is there some kind of a course for teaching healthcare professionals this within the NHS?
There are loads of courses on helping healthcare professionals have better conversations with patients that by definition will lead to more self-management choices. But first of all, you have to have the opportunity yourself and motivation to go on them, which also includes knowing that they're there. I would suspect that if an MS specialist isn't doing this right now, it's because they're not aware that they should be. It doesn't mean they've never been told, but they've dismissed. They may have been told and decided not to, and it's not in their mind that I should be doing something different to what I'm doing. So the first thing to tackle is to understand why that is and how you close that gap. So that, you know, they'd have to, behaviorists working on this, and if they did what we call behavioral de-risking with the clinicians, would on understanding that these conversations aren't being had as well as they could be, would then delve into why not. And this isn't, you know, I'm making very sweeping statements here, but based on, you know, studies and work we've done in many areas, guarantee one of the first answers is I didn't even know I should. And then I'm not convinced that I should. What are the benefits to make me interested in doing? And then I don't know how to. Or worse, as you get with some clinicians, I believe I know how to, but they don't actually know how to. We had this really interesting behavioural disconnect when we did some work on menopause, and it was something like 80% of GPs and practice nurses told us that they were confident in diagnosing and helping patients through the first few steps on their menopause pathway, that the data proves beyond any doubt that far fewer than 80% of them are doing anything like that. So there's a cognitive disconnect going on there. So I could probably talk all day on the possible reasons, but those ones are likely to apply.
Yeah, I mean, you know, I'm aware of an exemplar in the diabetes field where in type 1 diabetes, where there are particular courses that people with type 1 diabetes go on, and they get taught how to self-manage in terms of adjusting the insulin doses, etc. So, I mean, there are really good exemplars in the healthcare space, just that I get feedback from people with MS, from my social media interactions with them, that this is just not happening at a level that it should be happening in the MS space. I mean, just the example that national study on how to self-diagnose and manage urinary tract infections. It works wonders when it's implemented, but it's just not happening across the NHS. So I think we're going to need a bigger discussion than this. Maybe we, after this, we should think about how the MS Academy or, the MS Trust or the ABN, who look after neurologists, interact with NHS England to make this happen.
I do also wonder, in some ways, if we, like in the NHS, we are doing self-management, but we're not calling it self-management.
Yeah.
I know we do it a lot in psychology, that we talk about CBT and giving people a toolbox that when we finished our intervention, people can take that away and apply those strategies elsewhere. But I don't know if I would ever go in and frame it as self-management, which is maybe, a learning point for me as well. But I do wonder if some of these things are being done, they're just not being framed in the right way.
So one of the things that's come up, the NICE approved Sleepio, it's basically CBT for insomnia app, and they're actually paying for the subscription if you get it prescribed by a GP. I write to the GPs all the time about this, and the patients are having an incredibly difficult time getting the Sleepio app prescribed for them. And I think, this is a disconnect between NICE and NHS England, and even the general practitioners who are the people who control over that.
And as I understand, that's not even a new thing. That's been in for a couple of years now that GPs have been able to fund it.
Yes. So I suppose it's an education issue. There must be a better way of, maybe there needs to be a portal in terms of quality of life. So Rachel, since you developed self-efficacy, do you think your quality of life as a person with MS has improved? Because I think that's the bottom line.
Yeah, and I'll be absolutely honest. There was couple of years ago, about 7 or 8 years ago, I was in a pretty bad shape. And I don't know if it was triggered by the relapse with the eye, but I just saw everything heading south. And I'll be honest, I was a journalist by training, and actually it was you, Gavin, who said, why don't you start doing some writing for us? And that's kind of, and that helped me enormously. And I know it sounds like an obvious cliche, but I think it was just the very fact I was able to do something. I was helping some people, obviously helping myself, and it gave me kind of a role. And I know that some people, especially with chronic illness, will find a faith or religious or something along those lines. And I also think some people find it in, be it in nature or art or something like that. And that did have, I think you mentioned it, about having a higher purpose or finding some sort of meaning in your life. And that helped enormously for me.
Yeah, so I mean that's kind of what the social prescribing budget is meant to do, is to identify high-risk individuals and try and get the general practitioners to arrange social prescribing. But it's easier said than done. Some of the general practices are really, really good at social prescribing, and some of them are just not engaged with it. So again, it's a bit of a postcode lottery, this, in terms of relying on the gatekeepers. Matthew, can you bypass general practitioners, or they have to be an essential partner? I suppose they have to be an essential partner.
Well, I think general practice potentially is an essential partner, but general practitioner not necessarily. There are plenty, in fact, often supportive conversations with patients about supported self-care and self-management is done better by the other clinicians than the medics. That's not to say medics aren't good at it when they're capable and help to be capable and so on, but actually it's the practice, and partly because they have more time. So yeah, but equally you can go, the MS Society and so on, they all provide guidance on taking up self-management options. So you don't need to wait until you see, but it is a behavioral thing that many people need reassurance in order to have confidence and even permission from an authority. So sometimes the GP is vital just to provide that in a short conversation. And can I just on one of the, when we're talking about how people perceive self-care, one of our first behavioral findings when we started working in this area far too many years ago was that if you said self-care, people other than middle-class white people, if you said self-care, their unconscious herd deserted by the NHS. So they didn't hear this as a positive thing. This is how you try and get rid of me so I don't use your money. And when we were working in one of the areas where we focused on this, we came up with this idea, why don't you start saying supported self-care? So self-care triggered a negative response because it felt like you were going to lose support. So counter it by calling it supported self-care or supported self-management. And it significantly increased the number of people willing to consider it.
Okay, that's a really important message to get out there. So we shouldn't be, in terms of how we use the lexicon in the vulnerable groups. Christine, we're almost out of time. So I just wanted to know if you were given a big budget by the NHS, a grant to set up a supported self-care or self-management program, where would you start?
Where would I start? Gosh, I think what Matthew was just saying about that kind of cultural shift is the biggest thing, I think, is how we view self-management. And it might be about thinking about how we frame it, how we, what's the word, advertise it, how we sell it. And I think that would be where I would start. I would be starting by thinking, how can we promote this? How can we get this to be a thing that people talk about and feel comfortable with? I think that's where I would start if I was given a big budget. Matthew, you'd be well in with the.
I could spend it for you.
Yeah, yeah. So I mean, just to say that the third sector, the charities are quite good at setting these courses up and helping. But unfortunately, in terms of the kind of patients I look after who go to these courses, tend to be the highly educated, white, middle class, relatively wealthy patients. So you're talking to the self-converted in a way. And, we've got to be careful that if we do set these up, we, make sure we get the left behind patients, because they're the ones that really need it the most. And, we have this virtuous cycle. Yes, everybody thinks self-management course is fantastic, but these people probably would do relatively well on, without going on these courses, because they live in an information-rich environment, etc. So I think we have to be very careful if we do spin this out, that it's done in a way that targets the whole population, not just the small.
I think as well, not conceptualizing self-management as a single thing. So self-management can be different. Like, for example, if you're self-managing your medication, you might be doing that every day. If you're self-managing exercise, you might be doing that 3 times a week. If you're self-managing stress, it might be in response to a stressor. And I wonder if breaking it down is, almost like a divide and conquer of ways that we can try to establish this as well.
Yep. Okay, there's one question that's come from Nicole. Where do you see digital therapies, apps, supporting self-management? So Nicole, we kind of use the Sleepio app. I think digital platforms are absolutely essential in terms of these things. But again, they need to be evidence-based. And I would imagine if we're going to use them in the NHS, they have to be NHS approved, have to go through NICE, and they have to be shown to be effective and cost-effective. So yes, but not every app is going to do that. So I think developing a digital application, it needs to be evidence-based. I think we're going to have to draw to a close because we've got 2 minutes before the changeover. So I just would like to thank Matthew, Christine, and Rachel. You've been fantastic panelists. And let's hope we can get back to this topic, maybe symptom by symptom, because I think it has to go symptom by symptom in the future. Thank you very much.